Hey everyone, and welcome. Today, we're diving into one of the most common, and honestly, one of the most important questions we face in GI. You've just taken out a polyp, so what happens next? We're going to break down the official 2020 U.S. Multi-Society Task Force guidelines into a really simple, practical framework that you can start using on your very next rotation. Let's get right into it.
Okay, so picture this. You've just finished up a colonoscopy, you successfully removed a polyp, and the patient's in recovery. They look at you and ask this exact question. Answering this well is like a core skill. So this explainer is all about giving you a clear, evidence-based way to answer that question with total confidence, every single time.
But hold on. Before we can even start talking about when the next scope should be, we have to be absolutely sure about the quality of the one we just performed. Think of this as the bedrock. Everything else is built on this foundation.
And the guidelines are crystal clear about this. All the timelines we're about to go over, they all assume the first procedure was a high-quality examination. So what does that mean? It means you got all the way to the cecum, the prep was good, and the person doing the scope has a solid track record of actually finding polyps. If any of those pieces are missing, well, then these rules just don't apply.
So let's put some numbers to that. What are the key metrics to keep in your head? Here they are. You've got to reach the cecum in more than 95% of your exams. The bowel prep needs to be adequate in over 85% of cases. And then there's the big one, the adenoma detection rate, or ADR. That's the percentage of screening colonoscopies where at least one adenoma is found. That rate should be at least 30% in men and 20% in women. These aren't just suggestions, they're non-negotiable benchmarks for quality.
All right, so let's assume we've checked all those boxes. We've done a top-notch exam. How do we figure out what to do next? I want you to think about it as 3 simple pathways. This mental model is going to help you cut through all the complexity and organize your thinking.
And here are our 3 lanes. When that pathology report comes back, your first job is to sort the finding. Is it a low-risk adenoma, a high-risk adenoma, or is it a serrated polyp? Pretty much every polyp you find is going to fit neatly into one of these 3 buckets.
Okay, let's start with the one you're going to see the most, adenomas. The absolute key here is to correctly figure out if they belong in the low-risk or the high-risk pathway.
And the difference is actually really clear. Low risk is simple, just 1 or 2 small tubular adenomas. That's it. But on the right side, you see the tripwires that send a patient down the high-risk pathway. Finding 3 or more adenomas, any adenoma that's 10 millimeters or bigger, or any polyp with villous features or high-grade dysplasia. Any one of those things automatically moves your patient into that high-risk lane.
So what's the reward for being on that low-risk pathway? Well, this is a huge practice-changing update from the 2020 guidelines. The recommended interval is now 7 to 10 years. And this is based on really strong new evidence that shows these patients have a very, very low risk of developing anything serious.
Now, for the high-risk pathway, it's a completely different story. If your patient hit any of those high-risk criteria we just talked about, the interval is way shorter. The recommendation is a follow-up scope in just 3 years.
This table does a great job of summarizing it all and adds a little bit of nuance. You can clearly see the 7 to 10 years for low risk and the 3 years for those classic high-risk findings. But check out those middle cases. If you find 3 or 4 small adenomas, the guidelines give you a little wiggle room, suggesting 3 to 5 years. But once you hit 5 adenomas, even if they're all tiny, you're firmly in that 3-year high-risk category.
Okay, so we've got adenomas down. Now we have to totally switch gears and talk about our third and final pathway, the serrated polyps. And it is so critical to remember that these are a completely different kind of beast, biologically speaking. And honestly, this is the most important message for this section. You absolutely cannot apply the adenoma framework here. Serrated polyps have their own set of rules. Forgetting this is a really common pitfall, so let's make sure we drill this in.
So, what are these different rules? Well, if you find just 1 or 2 small sessile serrated polyps, we call those SSPs, the interval is 5 to 10 years. But just like with adenomas, size and histology really matter. Any SSP that's 10 millimeters or bigger, an SSP with dysplasia, or a traditional serrated adenoma, a TSA, all of those get a 3-year follow-up. And hey, pay attention to this last one. Even a large, hyperplastic polyp, which we usually think of as benign, gets a shorter interval of 3 to 5 years. That kind of shows you there's still some uncertainty about their risk.
So, that's the whole framework. I know we've covered a lot, so let's boil it all down to the absolute key takeaways you need to remember for your day-to-day practice. First, if you only remember one thing from this whole explainer, make it this. The most common finding you'll have 1 or 2 small adenomas now gets a 7 to 10 year follow-up. This is a major change, and you should feel totally confident recommending this longer, evidence-based interval.
Second, use the framework. It will save you every single time. When you get that pathology report, just ask yourself 2 questions. Is this an adenoma or a serrated polyp? And then, is it low risk or high risk? That simple sorting process will guide you right to the correct answer.
And finally, we end right back where we started. None of these recommendations, none of these intervals hold any water without a high-quality baseline exam. Making sure you have a great prep, a complete exam, and that you're tracking your ADR. That isn't just about metrics. It's the entire foundation of preventing cancer. Quality first, always.
You know, the trend here is pretty clear. Higher quality exams are letting us safely stretch out the time between scopes for low-risk patients. And that leaves us with a really fascinating question for the future. As our tools and our skills get even better, will we actually find ourselves recommending less surveillance, not more? It's something to think about. Thanks so much for joining this explainer.